is Danielle. I'm a nurse. I'm a master's student here at Dalhousie School of Nursing, and I'm here to present my scoping review. This is my thesis work titled Interventions to Change Clinician Behavior in Relation to Suicide Prevention Care in the Emergency Department. This is my first time presenting the thesis work, so findings and analysis are quite preliminary, so I look forward to feedback and questions at the end of the presentation. So suicide is a significant public health problem in Canada and also across the world. Every year, there are about 4,000 deaths by suicide just in Canada, which translates to 11 deaths per day. And the risk of suicide and the rates of suicide are the highest among youth and young adults. It is currently the second leading cause of death in Canada. And unfortunately, with the current situation of COVID-19 pandemic having significant impact on psychological health, the rates and the risk of suicide are expected to increase. There are many places where suicide prevention takes place, and the emergency department, ED for short, is one of the prime entry points for suicide prevention. Suicide prevention can be broadly categorized as screening and assessment or brief interventions, which includes safety planning or lethal means counseling. And there's also disposition and discharge planning or clinical management, which refers to documentation practice or safety management in the department in the presence of a patient with suicidal ideation or attempt. And regardless of this type of suicide prevention intervention being delivered to the patient, empathetic care and therapeutic relationship are at the core of clinical practice. And as you can see, suicide preventions are delivered in the context of provider-patient interaction, highlighting individual clinician behavior as proximal determinants of the quality of patient care. So to meet that increased demand for suicide prevention, we must ensure that evidence-based practice fully implemented, and one of the essential steps towards that is supporting ED nurses, physicians to make the desired behavior change following evidence-based suicide prevention. However, reviews have yet to investigate interventions targeting clinicians' behavior change, and I hope to address that gap with this scoping review. So because I'm looking at interventions targeting clinicians' behavior change, I need to consider a theoretical framework that will help me with this process of characterizing interventions. Behavior Change Wheel by Susan Mickey is a comprehensive model made up of 19 existing behavior change theories, and it captures wide range of mechanisms of behavior change, including those that are internal and external to oneself. And this model has been used many times previously by other disciplines to characterize interventions in behavior change terms. So the use of this model in this scoping review is one of the strengths. So to our knowledge, this is the first scoping review that will characterize and map all literature on interventions implemented to change ED clinicians' behavior related to suicide prevention. And there are two review questions that I'm addressing. Question one, what interventions have been implemented in EDs to change clinicians' behavior related to suicide prevention care? And what are the outcome measures reported in these studies? I followed Joanna Briggs' scoping review methodology, which includes the development of an a priori protocol. First, I started with developing search strategy in collaboration with librarian scientists. We applied the final search strategy across all the databases I included. I searched PubMed, PsycInfo, CINO, and Embase. Also, I included gray literature, including theses, dissertations, abstracts, So I included ProQuest thesis in global and Scopus for conference papers and abstracts. In addition to database search, I conducted a targeted Google search by using Godin's method to locate international and national emergency service organization websites to find interventions made for ED clinicians' behavior change. So participants were kept broad. As long as these healthcare providers were working in the ED settings, they were all included, including the medical residents in the EDs. And in terms of the concept, interventions must have an indication that it's changing clinicians' behavior. And the behavior change refers to, according to Susan Mickey, it includes observable changes in clinicians' practice, as well as proxy measures of practice change, generally including knowledge and attitudes or emotions. And knowledge and attitude do not necessarily lead to observable behavior changes, but they are still individual factors that influence one's behavior. So behavior, I use that definition of behavior change. So in terms of the context, all EDs in any countries were included as long as the article or paper was written in English. Two independent reviewers screened the titles, abstracts, and full text against the inclusion criteria, and all conflicts were resolved through discussion or with a third reviewer. Critical appraisal is an optional step for scoping review, but I decided to do critical appraisal to identify gaps in the quality of evidence. And critical appraisal was not used to exclude any studies. Data were extracted by two independent reviewers using pilot-tested data extraction tool to capture information on general characteristics on the study and information on interventions and implementation strategies, as well as the outcome measures. All conflicts were resolved through discussion or with a third reviewer. Extracted data were mapped on the behavior change wheel, and also the outcome measures were categorized. And 30% of mapped data were verified by a second reviewer who has the expertise in applying behavior change wheel. So I will share the results using Prisma diagram. From the database search, there were 8,713 citations, and of which 39 studies were included, and 2 additional studies were found through hand searching reference list of the systematic reviews that came up with this database search. So there were a total of 41 studies from database search. And from the targeted Google search, after screening 1,000 items and 56 full text, there were 29 items that met inclusion criteria. So in total, there were 70 items included in the scoping review. Only 33 studies were appropriate for critical appraisal. The mean score was 61% with standard deviation of 18%. So of the 70 items, 42 were studies, 41 studies were from the database, 1 study was from the Google search. The designs were diverse, but most studies, 24 studies were quasi-experimental, usually involving non-randomized pre and post-intervention designs. There are a few observational studies, mixed method studies, and qualitative studies. Most studies, 20 studies were from the States, 9 studies were from the UK, 4 from Australia, some from Asia, some from Europe, and this may be reflecting the language limitation that I have for the scoping review. 16 studies, only 16 studies reported their geography settings. 12 unique studies were located in the urban settings. Only 1 study was done in the rural area. 26 unique studies were done in general ED, and 7 studies were done at pediatric emergency departments. And 27 unique studies targeted nurses' behavior change related to suicide prevention, and 16 studies targeted physicians' behavior change. And few studies targeted other healthcare providers, including social workers, nurse practitioners, and psychologists. And this makes sense because most studies, most EDs have nurses and physicians only. Not all EDs have social workers on site or NPs on site. So 22 studies involved one type of healthcare provider, nurse being the most common target. 10 studies involved 2 different types of healthcare providers, nurse and physician being the most common target. Few studies involved more than 3 types of healthcare providers. There were a total of 29 items found from the data Google search, and one was a study which I reported its characteristics along with other studies with the studies found from the database search. And now there are 28 items that were interventions themselves that I found from the targeted Google search. The types of interventions varied, but most of them, so 14 items were guidelines or guides made for the ED clinicians. I also found online training course, care pathway, and video and webinars for the ED clinicians. 19 interventions were from the United States, 4 from the Australia. Again, this may be reflecting the language limitation that I have for the scoping review. So in total of 70 items, there were 66 unique interventions. So one intervention that I found from the Google search was actually used in 2 of the peer-reviewed studies. And also there were 3 peer-reviewed studies of 3 peer-reviewed papers of the same study, but reported different outcome measures. So there were 66 unique interventions, and interventions were related to 1 or more category of suicide prevention. So 50 interventions targeted clinicians' behavior change related to suicide risk screening and assessment. There are only 6 interventions that targeted clinicians' behavior change related to empathetic care. So interventions were mapped on the behavior change wheel, and the behavior change wheel here at the bottom. So the red ring represents intervention functions. So intervention functions are the mechanisms in which interventions cause a behavior change by targeting different determinants of behavior. And the core of the wheel, the green area, are the determinants of behaviors. So I think this matrix will be more helpful in understanding characteristics of the interventions in terms of behavior change. So this green column represents this green core of the wheel, representing determinants of behavior. So according to Susan Mickey, human behavior is resultant of interactions between one's capability, opportunity, and motivation. Influencing these factors may cause behavior change. And here the red ring intervention functions are located here, this row. There are a total of 9 intervention functions in the behavior change wheel. And each intervention function, they target different determinants of behavior. So for example, there were 48 interventions that used education. And usually education, this is a quote from one of the studies, education was used to increase clinicians' knowledge. By increasing clinicians' knowledge, we can improve their confidence. And by having more knowledge and confidence, we can increase the likelihood of clinicians being engaging in that specific behavior, for example, suicide risk screening assessment. There were 40 interventions that used the training method. So usually trainings are used to improve clinicians' skills or building skills. And by improving their skills, we can overcome any negative emotions that clinicians may have. So that's targeting capability and also the motivation. And there were 20 interventions that used some persuasion. So this is a quote from one of the posters. It says 10% of all ED patients are thinking of suicide, but most don't tell you. Ask questions, save a life. So using emotional phrase like this will influence, it will motivate clinicians to do more screening assessment. And there were 18 interventions that used in environmental restructuring, which refers to making changes in physical environment or social environment. So in this case, they put the poster up in their meeting rooms, lunch rooms, and the bathrooms. So they are making changes in the physical environment. Also, by putting a poster up, we are reminding clinicians to engage in that certain behavior. Screening and assessment, for example. So as you can see, 66 interventions were quite heterogeneous. 21 interventions out of 66 interventions used 2 different interventions simultaneously. So for example, 10 interventions had education component and training component together. And there are only 12 interventions that had single intervention functions. 22 interventions had 3 different functions, which means they target different determinant behavior change. And few studies had more than 5 intervention functions targeting different determinants of behavior change. They were quite heterogeneous, and outcomes were organized in this framework. So 42 studies reported outcome measures. There were diverse types of outcome measures. Most studies reported on effectiveness at clinician level, and that makes sense because I was looking for interventions targeting clinicians' behavior change, and most studies evaluated interventions effectiveness at clinician level. So 22 studies evaluated clinicians' knowledge change, so conceptual knowledge use. They assessed changes in knowledge, attitudes, confidence, and then 24 studies evaluated their observable behavior change by looking at their documentation patterns or by using self-report to assess the actual changes in their observable behavior. A very few studies reported on process outcomes like reach, adoption, and implementation, including fidelity. No study reported long-term outcomes of maintenance. So the results show that many interventions were composed of multiple intervention functions to target different determinants of behavior, often targeting knowledge and skills simultaneously by using education and training. And this is consistent with current literature, previous review of knowledge translation strategy in allied health professions. They also found predominant use of education in their KT strategy. Also in a different review of de-prescribing benzo interventions, targeting clinicians to de-prescribe benzos, they also used education and training frequently. So this is not surprising because in comparison with more complex interventions that require physical environmental change or organizational change, training and education are relatively less resource intensive. So that may be why that's influencing choice of intervention functions. However, we have to remember that changes in knowledge and skills do not necessarily lead to successful behavior change. So that's something we need to think about. And despite the existing suggestions for reporting clear description on intervention design, I found limited theoretical underpinnings in the 66 interventions or lack of reporting theories. And this is an area of concern because lack of theoretical rationale can hinder intervention design, replication, implementation, and we can't drive the maximum benefit of the intervention. And not many studies reported process outcomes or long-term outcomes. So I will discuss this further in the context of implications for future research. Measuring implementation outcomes will help us better understand the implementation process so we can know what worked and what didn't. And intervention will not be effective if it's not implemented well. So implementation outcomes are as important as effectiveness outcomes. Also, we need more research reporting long-term outcomes to increase sustainability. And again, research should report theoretical approach. And also, review findings highlight opportunities to target other behavior determinants. So instead of targeting knowledge and skills simultaneously, maybe we should look into motivating or making changes in the physical environment. Considering the critical score was 61%, quality of evidence can be improved. And we need more work in developing interventions targeting behavior change related to empathetic care, as there were only 6 interventions. Lastly, it was beyond the scope of this project to assess the effectiveness, but it will be useful to see in the future to assess comparative effectiveness of different intervention functions and combinations of intervention functions. So it will be useful to know if education plus training is more effective than using education alone, or education plus training and, I don't know, environmental structuring will be more effective than using education and training only. It will be useful to see those comparative effectiveness. So scoping review is limited in the language, and we have a limited understanding of the interventions identified from the Google, other than they are publicly available online. I don't know how they are being used, except for one intervention found from the Google search that was used in 2 studies. Other than that, 27 interventions, there's a limited understanding how that's being used in the real life. So thank you for your attention, and welcome any questions.
Hi, Danielle, it's Marilyn.
Hi.
How are you today?
Good, how are you?
Good, very nicely done.
Thank you.
Your comment, Danielle, or your observation that the interventions were not theoretically driven necessarily. So in your estimation or in your knowledge, are there theories that would have, does the theory that presently exists, if used, would that have made a difference?
I think so. I might be a little bit biased because I'm using behavior change wheel, and a little bit biased about using the benefits of behavior change wheel, but the behavior change wheel gives systematic approach of how to analyze clinicians' behavior, and then to strategically choose intervention functions to target specific barriers in terms of engaging in their behavior. So for example, if there is a lack of knowledge that's a barrier, then we know from the behavior change wheel, using education is one of the options for target lack of knowledge. So I think using behavior change wheel will be helpful in the intervention design. But again, I don't know if they're not using or they are not reporting it. I don't know. I can't differentiate if they are not reporting or not using it. But definitely if they report the use of theory, it will be helpful in terms of replication and implementation.
Thank you.
Are there any more questions?
Or feedback, because I'm still working through my analysis. So,
Danielle, I have a quick question. It's Christine.
hi.
Great work. You mentioned in your results and then in your discussion around matching the behavioral determinants to the intervention functions. And right now we know there's a lot of educational interventions and training interventions that are being used. Based on, I know you did a very comprehensive literature review and you mapped out all of the different behavioral determinants that are barriers. Is there one or two other intervention functions that you would recommend more research on to tap into some of those behavioral determinants?
Yeah, so there were moderate number of interventions that used persuasion or environmental restructuring. One example being integrating electronic health system to remind clinicians to do more suicide risk screening and assessment. That types of intervention functions that taps into like motivation and physical opportunity will be beneficial on top of education and training. But the effectiveness, I don't know that for sure, but that requires more research to identify the effectiveness between just using education and training alone or adding that piece to the intervention. But I would like to see more of the persuasion and environmental restructuring in these types of interventions that target behavior change.
Great, thanks.
Thank you, Danielle. So if we turn it over to Justine, if you want to share your screen, that would be great.
All right, everybody see and hear me okay?
Yep.
Okay, perfect. So today I'm going to be talking about providing essential coaching for every mother during COVID-19. So lessons learned from a postpartum text message intervention. So just a quick overview of the presentation. I'm going to do a little bit of background and how we pivoted, and then the modification, and then talk about the actual study. So the recruitment approaches that we use, the results summary, and then kind of the next steps of where we're going. So in terms of the background, Essential Coaching for Every Mother, the original development was done in the spring of 2019 as part of my dissertation. So what we did is we developed text messages to be sent to moms within the first 6 weeks postpartum. And we obtained patient feedback from 10 mothers and 18 postpartum healthcare providers using 3 rounds of iterative testing. So we showed them the messages, got feedback, revised them, showed it to another group, etc. And then we ended up with the design of the 6-week text message program that sends daily messages, twice daily messages in the first 2 weeks, and then daily for the following 4. So there's a total of 53 messages, and it started the evening of the 2nd day after birth. And the population we were initially targeting was first-time moms who lived in Nova Scotia who delivered specifically at the IWK. And we published the results of our design development and usability testing in women and birth. But we had to pivot a little bit. So there's 2 major things that happened. The first one is that shortly after we developed the intervention, I gave birth to my own first child. So this is my son, Owen. He's about 18 months now. So I was taking a year of maternity leave, and our goal was to launch an RCT to evaluate the intervention in June of 2020. But as we're all very familiar with, COVID happened. So that was, the RCT was essentially put on hold. However, as I was ramping up to come back, in conversation with my supervisor, Marcia Campbell-Yo, we really felt that we had to do something with this program. It was already developed to be a remote intervention. And with COVID, there was a significant drop in postpartum support that was available for moms. So there was no more public health drop-ins where you could see a public health nurse and talk to other new moms. And with physical distancing recommendations, there was there's a much reduced family and friend support. So we felt that it was really essential. So what we decided to do was modify it to be implemented during COVID. So what we did is we took a look at the messages that we had and to revise them for applicability during COVID. So what we did is we developed specifically 4 new messages related to specific care during COVID-19, such as new recommendations about the safety of breastfeeding and things like that. And we modified 10 messages. And of those, 9 were significant enough to be piloted. Again, to make sure that they were applicable. The ones that weren't, didn't deem to be significant enough only had minor wording changes. So instead of going to visit the IWK, if you're in concern with bleeding, just to call them first, like little things like that. So the ones that were significant enough, we reached back out to the moms and the healthcare providers who participated in the original development. And we had about a pretty good response rate considering the ratio of moms and healthcare providers. We had 3 moms and 7 healthcare providers agree to provide feedback on the revised messages. So during this stage, they felt that the messages were really appropriate and relevant to changes in care during COVID. A lot of the feedback was to make sure that the messages were framed in a positive light. So really about what parents and moms could do rather than what they can't do, as well as recommendations to provide links to the current guidelines to make sure that they have the most relevant information available. And this was a good suggestion as we were in the process of doing the modification. Nova Scotia went from the household bubbles to family bubbles to the Atlantic bubble. So it's good just to be able to provide the current links. So in terms of the final modification, we had 9 messages that were modified from the original program, and then we had 5 new messages added. This resulted in a total of 56 messages starting the 2nd day after birth. So during the first 2 weeks, there was an additional message sent 3 days to get out those extra 3 messages. So I just want to provide a quick view of what the messages look like. So this was an example of a message that we added about COVID-19. So there are things that they can't do, but then really outlining the things that they can do, focusing on their family, doing skin-to-skin contact, spending time outdoors while safely distancing, those types of things. And an example of a message that we had to change was around the public health follow-up. So normally it was within 48 hours, but due to the changes, the recommendations were then 3 to 5 days after discharge, a public health would contact them, and then it'd most likely be over the phone or online versus in person. So we decided to test this as a feasibility study, a pre-post feasibility study to help inform the RCT that we've since launched. But the first objective was to determine the feasibility of recruitment and retention of pregnant and postpartum women for essential coaching for a mother during COVID-19. And our goal was to recruit 75 moms in 3 months. Our secondary objective was to determine the preliminary impact on our key outcomes that we were interested in for the RCTs, so maternal self-efficacy, social support, postpartum anxiety, and postpartum depression, as well as we wanted to explore the acceptability of the message to kind of see what moms thought before we launched the RCT. So we used a 3-prong approach for recruitment. Initially, we had hoped to recruit moms in the family newborn unit after they delivered, but obviously with the limitations of in-person recruiting, we had to reimagine what a recruitment strategy could be. So we used primarily 3 different sources. So the first one was social media. So we posted on Facebook about how moms could contact us. And everything was done remotely. So we provided the information about how to text us to get the conversation started. We also had posters in the family newborn unit at the IWK, as well as the perinatal follow-up clinic, to encourage them to reach out and contact us as well. And we also did a few media interviews. So I did Halifax Global Morning as well as an interview with CBC to reach more parents. We also did recruitment at 2 time points. So we reached out to moms while they were still pregnant to kind of get them in the hopper to once they delivered, they could start right away. So women could enroll if they were 37 weeks pregnant or more, and then they're eligible to enroll in the postnatal period if they were under 3 weeks postpartum. And as I mentioned earlier, all consent eligibility screening questions and questionnaires occurred remotely via text message. So there was no in-person contact that I had with the participants at all. Everything was completely remote. In terms of the eligibility, women had to have given birth to their first baby less than 21 days ago at the IWK and must live in Nova Scotia. They had to have a phone that could do texting, over 18 years, and speak and read English. Oh my gosh, I don't think I'd fall under that one right now. So women were excluded if it wasn't their first baby. So if it was their second baby or more, they were not eligible to participate. If they didn't live in Nova Scotia or deliver at the IWK, or if their baby was older than 21 days at the time of the first contact. So I just kind of want to walk you through what this looks like, so you can kind of see how what a participant would see. So for example, a mom would text pregnant, so and then she would automatically receive the following text. So she would say, thank you for your interest. Here's a link for more information, briefly describing the study, and then to see if it's something that they'd be interested in. And if they say yes, we would do the eligibility screening. So whether they were over 18 and could read English comfortably, living in Nova Scotia and plan to deliver at the IWK, if it was their first baby. And then we'd ask how many weeks pregnant they were, and then follow up with their due date so that we could send reminder messages to help trigger them to send delivered as soon as they delivered, to ensure that they received as many messages as possible. And then once the message delivered, we would start more specific information. So when did they give birth, so that we can ensure that they received the messages based on the age of their newborn. And we also asked their name, their child's name, and their child's gender, as well as their preference for breastfeeding or formula feeding messages, so that we could personalize the content for them. And then we would ask them to complete a survey here at the bottom. So we opened recruitment on July 15th, and then we closed it on September 19th. So as I mentioned earlier, our goal was to reach 75 participants in 90 days, and we actually reached that in 50. We kept it open for a total of 67 days to ensure all the people who expressed antenatal interest could enroll, and we ended up getting 88 participants in total. So I just kind of want to walk you through our recruitment flow. So we had 200 women initially contact us, and of that 140 was in the antenatal period. Of the 140, 88 were interested, 58 were eligible, and 53 enrolled. And then of the remaining 60, 58 were interested, 38 were eligible, and 35 enrolled. So what we found overall is that 68% of participants who enrolled antenatally received the full program, so received all 56 messages, compared to only 17% of participants who enrolled in the postpartum period. So again, I just want to walk you through what the participant experienced and kind of what we found at each stage. So 70% of recruitment was antenatal. Interestingly, 65% of interested participants at both time points were eligible in both recruitment streams. Once they were recruited and enrolled, they were on average about 3.3 days old, their babies were when the mom enrolled, and there was quite a range from 0 to 19 days. Once they enrolled, they were asked to complete the baseline survey, and of that we received 80 fully complete surveys and 8 partials, and it was completed, those that fully completed, it was about 5 days after they enrolled. And again, it was a range of 0 to 19 days after they enrolled. once they completed the baseline survey and enrolled, they received the program, which was again 6 weeks of 56 messages total. And then once the messages were complete and the mom hit 6 weeks postpartum, she was asked to complete the follow-up survey. And of that, we have, again, 80 fully complete, 3 partials and 5 incompletes, so no responses. And again, it was about 3 days after study completion that the participants responded. So we received 77 fully completed both baseline and follow-up surveys. So we were able to reach our target of 75, which is very exciting. And we have 11 partially completed survey data. So we were able to use survey data from participants who, as long as they completed both the baseline and the follow-up assessment. So they may not have all of it, but if they completed earlier in the survey, we included their data. So on average, the enrolled first moms were about 30, 31 years old, mostly white. About half had a household income over 100,000. Most were married or common law, had an undergraduate degree or higher, and about 30% had a history of diagnosed anxiety and depression, which is actually about standard. It's about 40% for the general population. About 68% had a vaginal birth, 88 said this was a planned pregnancy, and they delivered around a mean of 39.4 weeks. In terms of the results, so for the objective 2 was we found that there was an increase in self-efficacy and a decrease in postpartum anxiety at 6 weeks, between baseline and 6 weeks. And there was no significant differences on depression, social support, or COVID-related anxiety and stress. In terms of the feedback on the program, 89 of the participants felt the messages were just right, so not too few or not too many. 85 felt the messages contained all they needed to know about newborn care. 95 felt the messages were helpful in light of COVID. Almost all would recommend it to other new mothers. And overall, mothers rated their satisfaction with essential coaching for every mother about 89%. So in terms of a summary, Essential Coaching for a Mother is a text message program that was designed for first-time moms in the first 6 weeks postpartum. We were able to pivot our remote intervention quite quickly to be relevant during COVID-19 while still engaging participants to ensure it was really patient-focused. And there was a significant interest in the program, as evident through our quick recruitment process. And we do have some preliminary positive impacts of the program on self-efficacy and postpartum anxiety. In terms of some specific praise that we received, some moms commented that the timing of the messages were particularly relevant to newborn's development. So one mom said, there are a few days when I was wondering about something, and then the text message for that day would end up being related to what I was thinking about. And just kind of a side note, I initially piloted these messages. It varied when I first developed it with myself, and I actually found this as well. So I found that reassuring that other moms felt that as well. There's also a normalization of what to expect with the newborn. So messages of the witching hour normalized our witching hour, and I felt less concerned that something was wrong and more confident that this was normal. As well as they were really confident in the information that they were getting. It made me feel more confident in the information I was obtaining than what I would Google. So that's reassuring. There were some areas for improvement that moms commented on, such as being able to tailor opt-in for additional messages, such as tailoring it to responses of mothers if they have certain issues that they would like more support on, such as breastfeeding or colic. To continue beyond the first 6 weeks. So I'd love it for it to go on longer, even the text came less often, but continued until 6 months. At 6 weeks, I feel like I've just figured some out, but she's still not sleeping great and is gassy, so I still have a lot of questions and know we've lots of ahead of us to figure out with months 4 to 5 based on other mothers. And mothers also mentioned that they would have appreciated it if their partners could get it as well. So I ended up sending him a screenshot of the messages most days, speaking of sharing the messages with her partner. There were some limitations of our study. Obviously, as a feasibility study, it wasn't really designed for power. And so the results really need to be interpreted with caution. And as a pre-post intervention study, we can't really say the true effects of the essential coaching for every mother alone versus normal changes that occur in the postpartum period because we have no control group. And then there was also variation in when women enrolled in the program. So under half of the participants received the full slot of messages. However, when we looked at this in the analysis, there was no clear trend or influence of the number of messages that women received on any of the outcomes. So when we controlled for it in the analysis, it didn't make a difference. So there doesn't appear to be a role of the number of messages played on the outcomes. And we're also unable to determine how many messages moms read and things like that. So kind of our next steps that I'd just like to share with you, and then I'm interested in hearing your questions and feedback, is that we are launching the randomized control trial after all. We finally got approval and all the changes that we made to make it better. And we launched last week, so January 5th. And we've already enrolled 6 participants, so we're very excited about that. We did make some changes based on the feedback. So we did make some changes to the messages based on the feedback from the feasibility study. So we removed some of the COVID-specific messages that we had added and modified them based on the comments and the current prevalence rate in Nova Scotia. But we did include some because there obviously are some changes that are still recommended, such as calling first or the delay in public health follow-up to 3 to 5 days. And then we also expanded it to all of Nova Scotia. So we removed the requirement of having to deliver at the IWK. We felt that this was more comprehensive to reach all areas of Nova Scotia. And there was only minor tweaking of the messages that we needed to do. So we felt that this was a good next step. And we also removed the requirement of first-time mothers. So we decided that we would do stratification based on parity. So we can see if there's differences in the outcomes based on whether moms are first-time moms or more than that, to see if there's any differences based on that. And we also reduced postpartum eligibility to 10 days from 21 days. So while we found no influence on the number of days, a number of messages missed, we felt it was important to kind of reduce the number of days postpartum that women could enroll. Because of the way that the program is structured, most of the messages, a third of the messages come within the first 2 weeks because they receive 2 messages a day in the first 2 weeks. So by minimizing the number of days postpartum that women can enroll, it does ensure that they received more of those messages. So we'll see whether that has like an impact on our recruitment as well. So the objectives of the RCT that we just launched is to compare the impact of essential coaching for a mother compared to standard care. So they received no messages on self-efficacy as our primary outcome and whether it differs based on parity. And the secondary objectives are to compare the impacts on social support, postpartum anxiety, and postpartum depression. And again, whether this differs based on parity. And we also add an exploratory objective to explore whether there's any longer term impacts on essential coaching for every mother on any of the above at 6 months postpartum. So we added a 6-month postpartum follow-up to see whether there's any long-term differences, but we didn't add any kind of messages throughout. That's kind of like a next step, but we're hoping to see if there's any long-term impacts as well. So the eligibility to enroll now, they can again, we're doing the antenatal and postnatal enrollment. So to enroll antenatally, they must be at least 37 weeks pregnant and again, have daily access to a phone, over 18 to speak and read English. And to enroll postnatally, it's again, all of the above, as long as they have an infant under 10 days. So in terms of recruitment, in terms of the flow that participants will walk through with the for this study is slightly different. So they'll again be recruited. And then once they enrolled, they'll be dichotomized into multipares and primaires. And then from those, they'll be randomized into either essential coaching for every mother or standard care. So we're hoping to get 35 per group. So a total of 140 participants in total. So again, we're recruiting on social media, as well as we have posters in the family newborn unit in the perinatal center, and we're working on getting it into the antenatal clinics as well at this time. So that's all I have for my presentation. I'm happy to have any questions that anybody has.
Hey Justine, it's Sandra Murphy.
Hi.
I have some questions.
Sure, yeah.
I love this study. It's awesome. And I think it's really wonderful that you're undertaking it because it's really important. Can you tell me about how you know that there are differences in depression and anxiety? Are you screening people, or how do you know that
So
the baseline
they
is
have at baseline and follow-up, they complete a survey. And in the survey at both baseline and follow-up, they complete standardized measures. So there's a standardized measure on self-efficacy, social support, and then postpartum anxiety and postpartum depression. So we're using the postpartum specific anxiety scale for anxiety, and then the EPDS for depression. So they completed at both time points, and then we measure the difference.
Cool, thanks.
Yeah.
Another comment. So you use the word delivered a lot, and I'm wondering if you would consider changing that. I don't know if you're familiar with Rebecca Decker in the US and evidence-based birth, and she has this wonderful book called Babies Are Not Pizza. They're born, not delivered.
Okay.
And I'm wondering if you would maybe consider changing the language. I find it very medicalized, and really like kind of implies that birth is more of a passive thing than it actually is. Just some feedback for you. And also the other language thing that sticks out for me is mothers. And I know we kind of maybe fall on different sides of this, but do you have people participating who don't identify as mothers?
So primarily no. When we do the posters, we're very conscious of that and don't have mothers as like, are you a new mother? So we are aware of that. I do ask that in the RCT, how they identify both their sex and their gender. So we're able to tease apart some of that differences. But for the feasibility study, no, it was mostly like all women identified as mothers.
Yeah, I think that's the case generally, no matter what language you use. You generally get the cisgendered, like middle-class white people.
Yeah,
for sure. But something to consider as well. But it's so awesome. I'm happy to help spread the word for you.
Thank you. I would really appreciate that. Any other questions or feedback?
Hi, Justine, it's Elizabeth.
Hi.
I was wondering if you had any thoughts as to why you saw an improvement in anxiety and not depression?
Yeah, that's, yeah, we're not quite sure what's going on with that. With this, with the feasibility study, it was in the state trait anxiety scale inventory that we saw the decrease in postpartum depression, but not in the postpartum specific anxiety scale. So they asked slightly different questions. So the state trait anxiety inventory, it asks like, do you feel within the past 7 days, do you feel calm? Do you feel nervous? That type of stuff. Whereas the postpartum scale was very specific. Like, I'm worried that something's going to happen to my baby. I'm worried I'm not going to know what to do. Kind of things like that. So it's really, we're not quite sure why one scale found a decrease in anxiety, but the other one didn't, and there was no corresponding difference in depression. So that's why we added that 6-month follow-up as well, because we're hoping to kind of get at that like longer term, whether there's any particular difference in doing it immediately after birth and then 6 weeks and then a 6-month follow-up to kind of see if we can kind of tease apart some of that difference that we did or didn't find for those outcomes.
Thanks.
It's me, Sandra, again. Sorry. I might put forth a hypothesis on why the anxiety is different than depression, and that typically postpartum anxiety disorders are related to lots of like worry and nervousness about caring for their baby and related things. And I think your text messages probably address a lot of that stuff. So it's helpful in terms of people's anxiety levels being lower. And postpartum depression presents a little bit differently. So unless you're kind of directly targeting things like mood and motivation and activation and stuff like that, you maybe not going to see so much of a difference with the depression. But the EPDS has that subscale too. So you could look at the anxiety subscale in the EPDS to have an even like a third anxiety related.
Yeah, we were thinking
if you want to add another
well.
measure, yet another.
Yeah, exactly. The interesting thing is that the one that looks at more specific anxiety, like that you have, like concerns that women have in the postpartum period, didn't find a difference. So, whereas the more general one did. So, yeah, we definitely have to dig a little bit deeper to kind of find out what's going on with those ones for sure.
Justin, just curious about using text message, because there are many ways you could have deliver that coaching. Like there are apps, web-based, or because I'm sort of interested in that kind of types of interventions too. So I'm curious why you chose text messaging versus others.
Yeah, for sure. It was a very conscious choice to use text messaging. Mobile apps limit the people that you're able to reach. Like they're required to have mobile data. It's more of you can do push notifications, but the participant has to like go into the app and use things like that. Whereas text messages, people just need to have access to a phone because it's only a one way. They're not responding very often. So it won't use a lot of their data or minutes or messages up. So it's free for participants to receive the message. It's focused on being a push notification. They don't have to actively go into the app and look at the content. They receive it right on their phones. And it does allow us to reach people from more low socioeconomic status who may not use their phone for any other purpose other than texting. So that's why we went with like a text message program.
Right. And you were able to reach those with lower SES?
We're targeting that for the RCT. We're working with family resource centers to try and get at more of that population rather than just like the social media recruitment.
Thank you.
You're welcome.
Thank you both for presenting. And if anyone has any questions, they can email or email me and I can forward them on. And thank you to everyone who attended.
Thank you.
Thanks. Goodbye.
Bye.